You guys have the best questions.
One more follow-up on
Yeah.
that then. Because there's two of us,
Uh-huh.
and her mom had breast cancer, so we'd almost have to do both of us for that to be effective, right?
Well, I agree. I think you can't blindly say, well, let's look at dad's genes and, we're all clear here, and then, never mind that your children are 50% mom and 50% dad, right? So anytime we have somebody in clinic, like when we get down to that generation, we'll automatically look both sides. And that would be a case where, like, let's say we're meeting with your son and he says, whoa, there's all this cancer history on my mom's side too. We would either say, well, let's just do the panel on you, or, let's bring your mom in and see if we can figure out exactly what's going on over there. And it's kind of interesting too, because these genes, especially like BRCA1 and 2, like if the mom has a BRCA1 mutation and the dad has a BRCA1 mutation, then it becomes a very serious situation for their offspring, because there's a condition called Fanconi anemia that's caused by having 2 copies of these mutations. And so we're really cautious. Now, obviously, if you had all your children, it's pretty clear they don't have Fanconi anemia, because it's pediatric cancers and limb malformations, for example. So, it's pretty obvious. But when we're at the age of folks who are, reproductively active or thinking about having babies, it becomes an issue. Yeah. It's a lot to think about.
How often do you find a person that has more than one gene mutation? And then if that's the case, how do you know which mutation is causing the problem?
Right. I think that in the last 23 years, I could count the number of those people on this many fingers. So it's pretty rare, but it does happen. And what's interesting is that, like, if I have a lady with a BRCA1 and a BRCA2 mutation, you would think that would be like, whoa, she's got 100% risk of cancer. But the genes kind of compensate for each other, because you still have a normal copy of each. And so it's not quite as severe as you would think. But for the kids, the risk is obviously much more than 50-50 then. Yeah, good question. Not very often, though. I think the other part of your question was, how do you know if it's tracking with the cancer? So I think Carol over there, mentioned different types of cancers like thyroid and breast, right? That could be related to a gene called P10. But, if you had a second mutation that was more colon cancer and your dad had colon cancer, you might know that that's tracking that way because of the cancers that it causes. So it's a little bit of like connecting the dots. And I've gotten like more and more humble, I think, over time, because I used to feel like, oh yeah, we got it, we figured it all out. And then I look back at like things I did 10 or 20 years ago, and I'm like, oh, that was just baby steps. So I try to be really humble. Good, yeah.
So going back to the previous question about offspring status, suppose the offspring does show one of these mutations. Are they not now working on ways to correct or delete mutations in the individual? So even though they have it now, it might be altered in such a way that it will not become a complication?
Well, I did my thesis work on that back in 1992 to 94, and we really didn't get very far, I've got to say. And I think gene therapy is not really there for most conditions, including all of these genes. So there's not really like a correction you can do, unless you're talking about, if you're doing in vitro fertilization, then you can select which embryos you want or don't want based on the gene mutations. But no, there's no real gene therapy. There definitely are, like pills a person can take, not so much with prostate cancer, but like with breast cancer, there's a pill called tamoxifen you can take that reduces your risk of breast cancer in half. So that's a pretty big step right there. Excuse me?
I mean, on the geo, forget it.
We always think it's coming, but like I said, got really humble about that too. Yeah, good question. So I just want to say a few words about Lynch syndrome, and I've got another family tree that I'll show you. Are we doing okay on time? Okay, tell me if I need to hurry. Do you have like a hook or something you can? Okay. So Lynch syndrome, this is sort of a table of what is Lynch syndrome. And there's all these different genes, MLH, MSH, MSH, PMS. And these are all the different cancers that are related. And what's interesting, so yeah, these people are at high risk for a lot of cancers. And these genes are so interesting and so common. It's like 1 in 200 Americans have a Lynch syndrome mutation now. So if I had a nickel for like everybody I've known from parts of my life that have come in to me and had Lynch gene testing and had mutations, I probably would have a lot of nickels. Maybe, $2. But what's interesting about this is that even though it's pretty well acknowledged that prostate cancer does have an increased risk with Lynch syndrome, you don't see it on the list. So it's like, hey, what's going on? So this is due for an update. Remember I said these all update a couple times a year. So this is a 2016. They haven't updated it yet. And I imagine next time we see it that prostate cancer will be on it. But the pedigree I have for you here, the family tree, this is like a knock you over the head. This is definitely Lynch syndrome kind of family here. So in this case, it's this guy who's coming in and he's wondering with his sister about their risk. And they have a brother with pancreatic, a sister with endometrial or uterine cancer, a mom with breast cancer, a dad who had prostate, colon, and stomach, who was Gleason 7, who had a sister with kidney cancer, a brother with prostate, cancer of the ureter, cancer of the breast, and prostate up here too. So you can see the prostate pattern, you can definitely see it, and he's, high grade. So he would have been a great person to test, but he was deceased before we could get started. And this guy was really pretty recently diagnosed, but has a pretty poor prognosis. So we ended up testing him, finding a Lynch mutation, confirming it in her. And then she actually has the Lynch mutation, and he does not. So that was kind of good news for him. But these are all related. This is like a super obvious Lynch syndrome history family, where you would never think like the prostate cancer necessarily fits in with all of that, but it does. It definitely does, and you can see the track right there. So we're still working on testing. We've got the mom coming in on this one pretty soon just to see if she's negative, because that would mean he would have to be positive. And I'm hoping that we can do a little testing over here too. So any questions on this one? Yeah.
So for example, a man that's deceased that had just 3. Now that people are having more colonoscopies and getting polyps before they get to the, does that figure into any of your risk factors?
Yes. So Lynch syndrome can include an increased risk of polyps, of course. If you have a lifetime risk of 80% to get colon cancer, you're probably going to have some polyps along the way, before that develops. And I think that's a really good question. So yeah, I always ask patients about polyps in their history, because there are also some other genes, I call them Lynch-like genes, that look a lot like this, but they have more polyps, like POLE1 and POLE. So yeah, polyps is important. And we usually say, like, if you've had 10 or more polyps and you're sort of on the youngish side, like 50s, or if you've had 20 or more polyps and you have a more advanced stage, like maybe after 65 or 70, then that's a significant amount of polyps, and that's a genetic test criteria right there. Lots to look at. Okay, I'm going to keep trucking here. So this just reminds me to say that there is definitely some research with prostate and Lynch, and that Lynch syndrome we think has maybe a doubling of risk. Although if you looked on some of my other slides, you would see probably slightly different numbers on that. Yeah. All right. So this is NCCN Guidelines, and so when I was telling you, if you want to, you can go to www.nccn.org/patients, or if you don't want to do the patient part, if you want to go the physician route, you can look that up and register. So you would look for this, the prostate cancer, and this is a very updated version. It's the second version already in 2017 that I'm going to show you. And this is the first time where the NCCN Guidelines have finally said, hey, men with prostate cancer may have germline mutations in any of these genes. So these are the genes that we're doing the testing on. So it's really exciting. And here's a list of all the labs that I've kind of highlighted along the way that are offering, different man panels for prostate cancer. And the genes are a little bit variable, and sometimes we add more and sometimes we add less. I sort of think of it as like I'm a chef and I'm talking to you about your family history, and I'm going to add in a couple genes here and a couple of these genes and make just a special sauce for you that's just right. So I think it's exciting that finally the NCCN guidelines are talking about prostate cancer. So the next two slides, what I did for you is I pulled from all the breast and the colon and all the other types of cancer literature, and I made like really good lists for who should have genetic testing? What are the criteria for inherited testing? And the first slide is more of the breast ovarian slant, and then the second slide is more of the Lynch colon slant. So there's a lot on here, but I don't know how I made that happen where it actually waves, but that's kind of fun, isn't it? If you have a known mutation in your family, well, that's a no-brainer. You're a good candidate. If you have metastatic prostate cancer, you're a good candidate. If you have Gleason stage 7 or higher, you're a good candidate. If you have early onset prostate cancer, which there's a lot of debate about what does that mean, maybe under age 60, multiple generations. If you have a personal history of prostate cancer plus one relative with any of these are all like no-brainers. Ovarian cancer, breast under 50, what's called triple negative for the hormone receptors, breast cancer, male breast cancer, or two relatives with any of these cancers. We also take into account, maybe if all your family died in the Holocaust or you were adopted and you don't really know your family history, we take into account limited structure. So those are factors to consider. And then also the Ashkenazi Jewish ancestry. Do we have any Ashkenazi Jewish folks here tonight? So Eastern European, yes?
No, I have some testing in my history.
Oh, okay, all right. So that's a very high risk group, basically because 1 in 40 of those folks have a mutation in BRCA1 and 2. So it's hugely frequent. So you don't even need a family history if you're Ashkenazi Jewish to have genetic testing. And then also, if we do some tumor testing, so if we peer into that tumor and we see mutations that look like they're hereditary, like BRCA1 and 2, then that's another indication to have genetic testing. Any questions on this one? All right, the next one is more of the colon-focused one. So here are all the Lynch syndrome cancers. You saw them in a table format already, so there's a lot of different ones. And if you have prostate cancer plus a relative with any of those, one of them or more, you're a good candidate. Or if you fit any of these instances where you have early onset or two tumors at the same time, multiple relatives, regardless of age. So, Lynch syndrome is very common, and so, it never surprises me when I find a Lynch syndrome mutation because it's just so frequent. Any questions? All right. So, I also wanted to point out in the NCCN guidelines, this is what, a urologist or a doctor is supposed to do when they have a new diagnosis of prostate cancer. So they're going to look at the DRE, and do the PSA, do the Gleason, and then they really should be asking about family history. So that's standard of care. And this list of questions here is, a little more general or global than the one that I just showed you. But, your doctor should be asking you these questions, and they should be considered in your workup, really. And then lastly, I wanted to illustrate that everything I've been talking about with genetic testing is clinical testing, where you come in, you pay for it, or your insurance pays for it, and you get it done at a commercial laboratory. There's also sometimes research-based testing. So I did a sort of a search here, and these were all the genes that I could find that they think may be related to prostate cancer risk, but more in a research arena. And so I think there is so much more of this to come after these genes are more carefully vetted. Most of them are autosomal dominant, but I actually did find here that there are a few X-linked cases of cancer predisposition. And X-linked means, the mom has two X's and she can pass the X on to the son, but a father cannot pass on his X to the son because he can only pass on the Y chromosome. So it's kind of gender linked. I don't know if those will actually come through, but it's interesting to think about different ways that this could be passed. And then lastly, this is a little bit of information about a prostate cancer genetics project. So if you are interested in getting involved in doing some research, but not necessarily, doing clinical testing, this would be a good contact for you. It's up at University of Michigan. They collect as much information as they can. They often want a blood or a DNA sample that they would analyze, but it would all be done on a research basis, which means no cost to you, but you may or may not ever get any results. Or if you did, it might take a long time. Okay, so now I'm going to shift gears to talk about tumor testing. Are there any questions otherwise about this inherited stuff?
Just because you have the mutation doesn't mean you're going to get the disease. They talk about epigenetics a lot
Yeah.
now. So
I like that you said that.
Or?
Yeah. So every gene I talked about was a predisposition gene, which means there's a percentage chance that you're going to get that cancer, but it's not 100, and it's usually nowhere near 100%. And so what are the factors that influence, that gene is going to trigger? Well, of course, there's, 20,000 other genes in your body, so there's an influence of all the other genes. There's the influence of your lifestyle. Are you a smoker? Are you a drinker? Do you have other risk factors? Are you exposed to chemicals or radiation? So those all definitely play a role, and probably other things that I don't even know about. Does that answer your question? Is that what you were thinking too? Yeah.
The gene doesn't have to be expressed, but it's because it's there.
Exactly. I don't think because you have a mutation that doesn't mean that you have cancer or that you even will get cancer. It just means you have an increased risk. Do you have a question? Okay. All right. So now I'm going to take off my inherited cancer genetic counselor hat, which I've been wearing for 23 years, and I'm going to try to tell you a little bit about somatic tumor testing. But I do want you to know that this is not my area of expertise. I've never ordered any of these tests myself. And so, I'm just kind of learning as quickly as I can to just stay up on it. I am part of what's called a genomic work group at TriHealth, where we vet new tests. We determine, does this look like one that, we all want to use or not? And so they look to me for the genetics expertise, but I have never diagnosed or treated a person with prostate cancer, and so, this is definitely outside of my territory. That said, I tried to put some information together and some, things that you can ponder, or maybe some resources that you can go and look at further. Okay, was that a good disclosure? All right. So, just to kind of wrap your mind around this, I want to clarify, everything that we've been talking about so far is an inherited or germline mutation. Germline means it's in the egg or sperm and can be passed on to the next generation. So now we're talking about testing a tumor that is an acquired or somatic mutation. So there's a big difference. Now you can imagine in this person's whole body, those inherited mutations are all there. And so, of course, if this tumor came from in here, this tumor also is going to have the inherited mutations in it a lot of the time. So it's kind of interesting when we do a tumor test and we're looking at the DNA expression or mutations in a tumor, we can sometimes spot those that are also inherited with a little luck. So that's part of what I try to do for our patients at TriHealth. So, again, in case that didn't come out clearly, the germline, like we're testing blood or saliva or something that represents all the cells in your body. Tumor testing, we're only looking at the tumor, so the mutation's only going to affect new cells that arise from that cancer, but not other cells in the body. And it can't be passed on. A tumor mutation cannot be passed on. So what we're looking for is this, an oncologic driver mutation. So this is what I tried to explain earlier. You're looking for mutations in the tumor that are causing that cancer to progress, either faster or slower, or become metastatic. And there's a whole wide range of genes and different functions that they have that we're looking at. So, kind of like this slide. This is a slide I borrowed from one of our oncologists, and I know chemotherapy isn't, one of the major treatments here, but the idea is that this is what we were doing before. We're just throwing darts, based on what we think is best for treatment. And then, this is the idea of, with a targeted therapy, knowing more about the genetic fingerprint or genetically what's going on inside that tumor, can it help guide us towards a different treatment? So, I've heard about this thing called PSA, and I think you don't want it to go up, right, unless you're a business person, right? But, PSA is obviously like the tumor marker that has been utilized most historically. And so now we're trying to put different dimensions on it. You've got your Gleason stage, and then you've got tumor testing. So I did get these slides on Polaris from my friends at Myriad. I do not work for Myriad. I have a lot more Myriad slides, and I don't want you to think that that means I think Myriad's Polaris test is the best. It just means that I had somebody willing to give me slides. So, their Polaris test, the idea is to, guide you of, are we going to do active surveillance, or are we going to go towards the treatment? And I really love this table. I think this has so much information on it, and so much information that is not my specialty. But I wanted to at least highlight to you that you can go on Nccn Guidelines and get this table too. And what I love is, so this is a table of available tissue-based tests for prostate cancer prognosis. And they list 1, 2, 3, 4, 5, 6. So 6 different tests, that they're aware of. So I highlighted right away in red, there are 2 that are not recommended after a review of this outside molecular diagnostic service program and, through NCCN. So it's easy for me to say, well, those are not recommended by NCCN. That's not my recommendation, but it's, it's clearly here on this table. So that leaves us with these 4. We've got the Decipher, the Oncotype DX Prostate, Polaris, and ProMark. So I don't know if you really want me to go through point by point on these, but what I noticed when I was kind of reading through that, if I was a urologist, which I'm not, or an oncologist, it seems like the Decipher test is focused more on populations that are post-RP, who have already had surgery, so who are maybe more advanced than these folks with the Oncotype DX and Polaris, where they're talking about people who've had a biopsy that's low to intermediate risk. Here again, biopsy, localized and immediate risk, localized. So, these 2, the Oncotype and the Polaris, seem to me to be a little bit earlier stage prostate cancer. Yeah.
How much material is needed for these tests, and how is it obtained if not by biopsy?
Well, if you had a surgery, if you had an RP surgery, there'd be a lot of tissue, there that you could work from. Otherwise, yeah, you could go on a biopsy, and it is an area of discussion that they need to make sure they get an adequate, piece of tissue that they can send. Most of these are paraffin fixed, so they're putting them in a block of wax in the lab, basically sending them off. But yeah, in tumor board, there's a lot of discussion of you better take an extra core, an extra piece of biopsy so that we can make sure that we have the right amount of tissue.
Is the standard 16 needle biopsy adequate?
I don't know, because
Yes.
I don't do those.
I had the Oncotype.
Uh-huh.
Yes.
Oh, good. So tell us about that.
It was after the biopsy was done, and actually it was in a different hospital, and they received the same slides as the one done in the first hospital. And all I said was, I want that test. I said, okay. And those slides were enough to go get.
Yeah, good. I've noticed, so with Oncotype, that is something that we've seen used for a long time in breast cancer. They use an Oncotype DX breast to decide, if you're over a certain number, you're going to get chemotherapy, basically. And so I think the Oncotype prostate is, similar, but with different driver genes that they're looking at, and of course a different outcome. Yeah, thanks for sharing that. Is there anything else you want to mention about it?
The only thing that I understood about the outcome was it gave me the % chance of metastasizing. That was really the number. And from that, you decide how urgent is my wanting to do something
Yes.
versus just active surveillance.
Yeah. I think the idea behind all of these tests is that they're giving you sort of another dimension of information, not just the PSA, not just the Gleason, but now we're giving you something that's genetic based. And it's interesting, like when I look at the Myriad Prolaris slides, they compare head to head with Oncotype DX. And you can see there's some difference here. Like Prolaris has 31 genes and 15 housekeeper controls, whereas Oncotype has 12 and 5. So is more better? I think nobody really knows for sure. And I think the people that could answer that are the people who have done a lot of these tests, which is not me, by the way. So.
And I didn't choose one versus the other.
Yeah.
Cleveland Clinic did.
Okay, so that's what they were
where I got it
using.
done. They sent it out, but that's who they sent it to.
Yeah, and I think different institutions are going to have an affection, more or less for, different tests. I know the Myriad group, the Prolaris group, just went and presented to the urology group here locally, hoping that they would use their test. And I think it's got to be really hard to know which one really is better because they haven't been out that long, really, that you don't have that much data.
Mm-hmm.
Yeah. So I think you had the Prolaris one, right? Is that what you said?
Just a comment. I had a Polaris test on the normal 12 shotgun sample, and there was enough. And then I had an MRI targeted biopsy the second time. It took 24 samples. And then I had the Decipher test on that. I don't know how much they needed, but I'm sure they had plenty.
Okay. So you had the Decipher test up here. And
on the second biopsy.
On the second
The first one I had the Polaris.
Okay, so you know everything here. So, tell us what information it gave you with each of those, and how did you use that information?
Oh, okay. All right. The second one, which the biopsy was April of last year, but the Decipher test has just got the results not too long. The information was, the Decipher score was 0.32. Okay, right? Genomic, low risk. Now, the column is risk at RP. Now, this Decipher has, most of their samples have been from radical prostatectomy samples, and that's how they kind of justify or confirm the accuracy of the test. But now they've expanded it to biopsy samples. So risk at RP, I'm not exactly sure what that means, but the risk of high-grade disease, primary Gleason being 4 or 5, was 15.8. So they give you a percentage. 5-year metastasis, they give you a percentage. Right? 10-year prostate cancer-specific mortality, 2.7%. Now, it sounds low, but I don't know what the 10-year mortality of an automobile accident is. So I'm trying to judge what that means, 2.7%.
I think they mean the chance that you would not be around in 10 years because of dying from
Well, I know
prostate
that's
cancer.
that's what it means, but I'm trying to, okay, what are the chances of mine not being around because I was hit by a car?
Right, yeah.
You know,
That's not factored in the tuition.
Yeah. It's hard to, put a stick and say, okay, I know that's a much higher risk than being hit by lightning.
Yeah. And it's got to be so hard to figure this out because now you have these new tools, with these new tests, with new answers, but how do you know what they mean? And how do you know how heavily to rely on them? Yeah, Carol?
One thing I want to mention, just as a heads up, I've had, for my cancers, several different genetic, both of them inherited of the tumor. Some of my medical professionals didn't really believe in genetic testing. So you may run across that. Don't be surprised. If even an oncologist says, that's too new, I'm not going to pay attention to it. Of course, I changed oncologists. I just wanted to give a heads up that even now that it's been around since you were saying 20 or 30 years, there are still many people that.
Well, I think you've got a really good point there. I keep track of all of the somatic tumor testing at TriHealth. And it's really interesting, when we graph out, different oncologists, some of them do, a whole lot, and then some of them don't use it as much. And some of it, is just based on the specialty type of tumor that they most often work with. So one of the tumor tests that I actually work with the most is called a Foundation 1. Has anybody heard of that one? So it's kind of like these tests, but it's not prostate specific. It's more global for almost any type of cancer. And, in that one, they're testing 315 different genes or drivers in the tumor. And, my job is to try to pick out which ones, might be inherited. But, it's interesting with those because the answer you get there are, is this a specific drug that's good for you for chemotherapy? Is there a clinical trial that you're eligible based upon these genetic mutations? So it's a lot more global and, less prostate specific.
But
Okay.
at the end of the day, the purpose of doing the test on the tumor is to determine what the best course of action is for you and your genetic makeup, correct?
100% yes.
Okay, so rather than everybody gets the same treatment regardless of your genetic disposition, now you've got something that's at least more targeted to what your body would accept, correct?
Yeah.
Is that the idea?
Definitely. I think the idea is that every tumor has some kind of a genetic fingerprint. It's got genes that went bad or, became mutated as the process of the cancer grew and grew. And we're finding now that a prostate cancer can basically look genetically identical to a breast cancer or some other kind of cancer. And you're going to treat those both the same based upon the mutations, that are the fingerprint, the genetic fingerprint. As opposed to, in former times, we were just binning everybody okay, you're a breast cancer, we're going to treat you with this. You're an ovarian cancer, we're going to treat you with this. You're prostate cancer, we're going to do this. And so now I think we're finding there's a lot of overlap and cross-relationship between different cancers because we're looking deeper into them on a molecular level, and it's humbling. So, okay, he's telling me I got 5 minutes. I have a couple more slides here about a little bit about Decipher and Prolaris. Do you want me to go over those?
Sure,
Yeah,
please.
okay. All right, again, not my area of expertise. So the Decipher folks did not respond to my request for data or slides. So, basically this is information off their website. But, like you said, they're talking about looking for the probability of metastasis after surgery. So I think they're trying to take a snapshot at surgery and say, how do you look from here on out from that? And there are some tumor testing companies, they're called liquid biopsies, where they take the mutations that are floating in your blood and they do it over time and they look how it changes. So that's like a more multi-dimensional look. So it's a genomic test and it's based on RNA biomarkers, which you don't see that often because RNA is really hard to work with, it degrades really fast and we have RNases on our fingers. But they do give you a website here for more, and I thought this was just such a cute picture that I had to put it in from their website. But they apparently have this 3D Explorer app that you can download for patients, and there's also one for clinicians, so you can just go crazy if you want to learn more. And you can also go on here and take their quiz, and find out if this would be an appropriate test for you. So that's what I have on Decipher. I have a lot on Prolaris, so you can basically just tell me to stop when you want me to. Granted, these are all slides provided by Myriad Genetic Laboratories, the commercial lab that has Prolaris. So, there could be some bias, of course, in these. But this one I thought was kind of interesting because they're looking at Prolaris is being recommended for all localized prostate cancer as opposed to Oncotype DX, which is here in the 3+3 and the 3+4, so only relevant for these, which Prolaris apparently can be relevant, clinically applicable for more. So I thought that was kind of maybe a plus about Prolaris, although if you were here, I think you could easily take your choice. This is just showing some of the, what they did in trying to find the genes that they're looking at in the tumor. So, if this is a normal cell and then it turns into a cancer cell and then all these cancer cells down here, what are the genes? So they started out with 126 genes, then they narrowed it down to 31 genes, and, now they have 9+ studies that say, they've got the right genes. But I think, like more genes or less genes, like what's really better, because what really matters is, do you have the right genes? Are you looking at the ones that are telling you what you think it's telling you? And there's so many other research labs developing tests out there thinking that, they're going to make millions of dollars, I guess, offering this test. So I think we have to be really careful about new tests that come by. And so that's why I'm trying to stay with like only ones that are mentioned on NCCN. All right. This is like a list of their studies, and here is some data coming from the last two studies, the Crawford et al. And the Shore et al. And so in this case, they have pretty good numbers. Like this is 305 patients among 150 investigators. That's a pretty big study. 1,206 among 124. And so these are all folks who were at the active surveillance stage after Prolaris. And I think what they're trying to show you here is that, in this study and in this study, the decision to have, surgery or radiation decreased. So, the blue bar is pre the test, and then the orange bar is post taking the test. So they're saying that people are really changing their mind based on this, and apparently feeling, good about their decisions as well. Questions?
What's AUA?
American Urology Association.
Oh,
Yeah.
so how they determine those?
Yeah. So yeah, they have, what is low risk, what is intermediate, and so I think it's easier for them to say like we're relying on their designations. Yeah. And then here's a picture of the report. So you described your report, Brett, so nicely. And here are the chunks of information that you get on any Prolaris report. So you have your usual clinical and pathology features that you would have had anyway. Then you get your Prolaris score, which measures the aggressiveness. And I have to say, like, I couldn't read these when I got them, and I still can't read them. Can you?
No.
But I think what this is saying is, like, if you're down here, that's good. It's less aggressive. And if you're up here, that's bad. It's more aggressive. And then here's the part where they give the mortality risk. So, like you said, yours was, I think, 2.5% over the 10-year risk. So I still can't read this very well, but it actually looks like it could be your test, and it might say 2%. So you get the mortality risk, and then apparently they give you a threshold, where if it's above this or below this, this is where you would decide to go with active surveillance. Recognizing that, I'm sure a whole lot of other personal factors, come into that decision as well. But that's what their report looks like. Any thoughts or comments? The other piece of the Prolaris data that they provided is looking at mortality risk. So I think what they're trying to illustrate here is that they have the people who are not eligible for active surveillance, so higher risk people, and then they have the people who, I think that's a typo because it should be eligible. And so you've got years since diagnosis progressing, and death from prostate cancer increasing. And so what they're trying to say here is that, they came up with this threshold of 3.2%, which would kind of like split these people in half. And so they're feeling like with this test, they can determine, are you on this curve or are you on this curve based on what the molecular profile is in the test. Thoughts on that? I heard there was a lot of engineers and doctors in this group. Is that right?
Engineers.
All right. We can do the engineer handshake later, right? I love data. I love numbers. But as you know, people can make it say anything that they want to. Maybe I'll make this my last slide, because I think this is the one that's the last kind of interesting one. So this is basically looking at Prolaris again, providing double the predictive power of the Gleason score in PSA. So like here's how much predictive power you get from the PSA. Here's how much you get from the Gleason. And then if you add the Prolaris on top of that, wow, look at all that extra.
They have an axe to grind. They have an axe to grind, though. They want to show that that's...
Yeah. And so I think these are interesting to kind of, think about and look. And Jim has my slides, so, you can certainly take a look at them if you like. But I think we have to be careful. Like, I would love to see Oncotype DX's slides, comparing themselves to Prolaris. Yeah.
Mary, I just gave you those slides. The one before, is that on their website? Yeah, is that on the website?
I don't know, because, I've had a long working relationship doing the inherited testing. So they were, of course, they took these slides to the urology group, and they were more than happy to give them to me to show you, of course, because they would love to be here doing it themselves. But I don't know if that's on their website.
They took them to the urology group, you said? The urology group of doctors have this.
They have seen this, yes. I'm sure they have seen this.
Okay, awesome. Because there were no observed prostate cancer deaths in men whose score was below the threshold. I don't see if there is.
Well, they're saying this is the threshold here, I think.
From their testing, it was less than 3.2%.
I think they're saying that's where we're splitting the hairs. But, I want to just go back to that one table that I showed you starting. I think this is a valuable tool for you. Like if you're looking for one of these tests and you want to talk to your doctor about which one, I think if you take this piece of paper, which you can find online or I'll happily give you, and say hey, which of these would be best for me? I think that would be a really good way to get your foot in the door and to fight against, I think, Carol, what you kind of alluded to is that there's a lack of awareness sometimes of genetic testing, and some institutions are more on it than others. But also saying hey, this is NCCN guideline. This is what you're supposed to do as a doctor. I think that also would kind of get things flowing a little bit too. Yeah.
Just out of curiosity, with all your years in the field, have you and your husband been genetically tested?
So, yeah, I love that question. So I've tested myself for every reasonable thing possible. And, mostly because I'm curious, and I know I would take some action if I found something. So heck yeah, I've done that. But also partly because I like to guinea pig test on myself. So there's a lot of direct-to-consumer tests that are coming out. Like there's one called Color, where for $250 you can put on your credit card. It's basically like 23andMe, but they'll test you for 20 different cancer genes, for inherited genes. And so I wanted to see, how good is this? Should I offer this to people? Because it's a lot cheaper. Is it as good a quality? And so I always am trying to evaluate stuff on myself. I also do a lot of DNA banking, which I think DNA banking is so important if you're in a situation where somebody is not going to be around for very long and they have cancer. I lost a parent to cancer, and by the time I became a grown-up genetic counselor, that DNA was gone, even his blocks were gone. And so I have actually DNA banked my whole family, much to my husband's chagrin. But for my kids, just in case they get kidnapped or something, and I need some DNA sample or whatever. So DNA banking is basically you draw blood, send it to a lab, they hold it for 20 plus years renewably, and it's like $150. It's really cheap. So I've seen enough families where I'm I really wish we could have tested, your grandpa, but grandpa's not around anymore. And so I offer it a lot, especially to, really deadly cancers like ovarian or pancreatic. So probably more than you wanted to know. But did I answer your question? Okay.
When my daughter was born, they said I should have got cord blood when you're just born.
Yeah.
Can you explain that whole thing?
Well, cord blood certainly would give her DNA, so it would be available. But it's more used for if she ended up having, or a sibling, maybe ended up having a cancer like leukemia or something, or eventually needed a blood transfusion or a bone marrow transplant in that kind of a situation. So I personally don't use it. I am not part of that at all. But I can see where it's helpful. Other thoughts? Okay, well, thanks, guys. I appreciate it.